Hello, I'm Eric Topol. I'm with my co-host Abraham Verghese, and we have the real privilege today of being able to have a conversation with Bob Wachter, the chair of the Department of Medicine at UCSF, a friend of both of ours, and a chance we were going to talk about AI, but there's something happened in between. And let me turn it over to you, Bob, to tell us a bit about the story, the thread that went as viral as you could imagine when you described your recent experience with COVID.
Yeah, Eric, I was just trying to see if anybody was still on Twitter, and I guess the answer is yes. First of all, it's a joy to be two of my favorite people and role models in the universe. It's really a wonderful chance to be with both of you. So I'm 3.5 years into this. I've been a Novid, and which I thought was a combination of vaccination, being fairly careful, and dumb luck, and had a feeling at some point the gig would be up. And the gig was up for me about 8 or 9 days ago. I developed a cough and then a sore throat and the usual thing, and had a pretty miserable night where I was very febrile and sweating profusely, and got up in the morning and felt like crud and decided I was going to take a shower, which seemed like a reasonable thing to do. And the next thing I knew, I woke up on the floor of my bathroom in a puddle of blood. Looked at the garbage can next to the toilet, and it had a head-shaped impression in it where obviously my head had struck. And luckily, my future son-in-law is an intern in medicine in my program, and called him up and said, Joe, I think I probably need to go to the hospital. I thought I just needed stitches. And it turned out it was, a significant amount of head trauma. And by the time it was done, I had a subdural, I had a C3 vertebral fracture, luckily non-displaced, needed about 30 stitches, and of course had this diagnosis of syncope, which I think was vasovagal. And as I've told many friends, only I could figure out a way of finally having COVID and having it be problem number 5 on my ER problem list.
Yeah, Bob, I'm so glad that you got away with, as little trauma as you did. It could have been a lot worse. I must say, it was taken again with your optimism. Katie, your wife, tweeted that your first remark to her was, "Don't tell the dog," which I thought is so typical of you.
Thank you. Yeah. No, I as you know, I've always had the attitude, if you can't laugh about it, it's not even worth talking about. So, yeah, obviously she was away, and so she was incredibly concerned, and people have been lovely. I mean, when I put it on Twitter, it was partly because I think like the three of us, we look for teachable moments, and I thought, the moment really was COVID's still around. People are still going to get it. They can still get pretty darn sick, even if they've been vaccinated. So I thought, maybe a few hundred people would notice it, and then it was one of those tweets that, started going viral, and then when CNN called and said, we'd like to run a story, and then the next day it appears on their homepage just below Wimbledon. Kind of pissed me off. I thought it was a better story than Wimbledon final. All of that was amazing, and people have just been, there's the usual foolishness on Twitter, and you deserve this, and this is what you get for not being careful. But for the most part, people have been magnificent, and it's been actually gratifying in a way that I would have preferred avoiding.
Well, it's striking. Abraham and I get to see you during this interview. Many of the people listening or reading the transcript won't, but you're healing quickly, and it's gratifying not only to see your optimism, your ability to joke, and your willingness to share, as you say, an extraordinary teachable moment, because at the same time, yesterday, on the New York Times, David Leonhardt is publishing "The Pandemic is Really Over." And unfortunately, a lot of people are thinking that this virus isn't even out there anymore.
Yeah, it's such a weird moment. I think as following you for years, Eric, and, incredibly grateful for the education you've done of all of us. At some level, David's article I thought was good. I mean, the statistics are the statistics. The death rates are no longer, different than the usual death rate of this time of year. And so that is a remarkable achievement, and says something about the state of the pandemic and the state of immunity, either from vaccines or from infection or both. And it's worth celebrating, and it is worth going back to something that feels a little bit more closer to normal than we've lived for the last 3 or 4 years. But you have to do it with your eyes open. When I decided a few months ago that I was now going to be willing to eat indoors, for example, I did it with my eyes completely open. And I said, there's a moderate chance that at some point I'll get COVID. But the cost of not doing that, seemed too high. And I also had this feeling, in which I continue to have, that it's probably not going to be any better than it is now. 3 years from now, 5 years from now, probably could be a little bit worse. But this is sort of it. This is the new normal. And it's, COVID will now be baked into the list of day-to-day risks that we all have. And all of us have to come to, some sense of clarity of like, how are we going to live our lives in a way that's fulfilling and maximizes joy? And for me, I decided to be a little less careful. I still have been masking on airplanes, but knowing that at some point I was probably going to get it. I didn't think I'd get it quite like this, but it just shows, it can do bad things to people. Even, not the springest chicken anymore, but I'm not that old and really don't have any significant medical comorbidities, and it still nearly killed me.
Talking about airplanes, Bob, I, as you guys know, I've been on a book tour for about 10 weeks now, and I began masking the whole time, on planes, and being very careful about social distancing, and just gradually it just wore me down. I was the only one doing it, and I began to just stop, and I completely forgot about it. I think I've been incredibly lucky to still be in COVID.
Yeah, I wanted to get back to your important point, which I agree with, about the progress we made on reducing fatality from COVID. There's no question, even if you look at excess mortality, as you alluded to. I think the issue, of course, is for us novids, as you were very recently, we're highly susceptible, no matter how many shots and boosters, because this virus is insatiable for finding new hosts, and particularly those who've never been exposed to the full virus. So there's the chance of staying COVID over more time, of course, is going to be less. And the other thing, a footnote, I wonder how many people, have a problem like you had who never even get tested, because testing now has gone down to really low levels.
Yeah. No, I think it's a really good point. I was on clinical service, so I was particularly attuned to testing because obviously I didn't want to bring the virus into the hospital. And my first test, the morning when I woke up and had felt really crummy for at least 12 to close to 24 hours, my first rapid test was negative. There was no question I was viremic, and I felt the full crud. So the test isn't perfect. My next test 6 hours later in the ER was floridly positive. So it was right at the moment it was turning. But yeah, I mean, in the same way people forget about tests, forget about masks and throw caution to the wind. Once they've run out of their home tests, are they going to go to Walgreens and spend $30 to buy some more? I'm guessing they're not. And so increasingly, this is just going to be folded into just the set of respiratory viruses that people are going to have. And, it'll spread as it spreads. But I do think the job of staying a novid forever is going to become hard. That's going to be tougher and tougher to pull off unless you're being super careful, probably forever, which is a hard thing to do.
Both Abraham and I in this Medicine and Machine podcast have been trying to really get into what leaders in medicine and in computer science think about AI. And as you know, and we've previously discussed on your podcast, Bob, with the large language models, not just ChatGPT, GPT-4, BARD, and others, there's a big question about, is this just statistical advantage, so-called a very smart parrot, a stochastic parrot, or is this machines that are at a higher level of intelligence than we've ever seen? And so maybe we can start off, what do you think about this?
Well, I struggle with it, and I think you probably need to bring on some philosophers to to answer that question. I mean, if intelligence is the ability to learn from experience and to sort of problem solve complex problems, I don't have much doubt in my mind that these machines now can do that, and in many ways can do it equal to humans, and in many ways better than humans. And I think, you know, as you well know, I mean, we're only looking at a single point in time. I mean, there's no reason to believe, you know, I think about GPT-4, which I use all the time now, and compare it to the state of AI, at least that was available to folks like me a year or two ago. I guess there's no good reason to believe that 2 years from now it won't be that much better. And it's hard to come up with a version of the Turing test that's not super biased in favor of the humans, that doesn't say that it's meeting all of the criteria that we think of as innate intelligence. And now, as you know, as you say, it's not actually intelligent. It's not actually a person. It actually does not have empathy, but it can express it in all the appropriate circumstances and in the right way. It can solve really, really complex problems that are far more multidimensional and nuanced than the ones we've ever had. It can have conversations at least as articulate as I can. And so, you know, I think at some point we have to say, if that's not intelligence, what does that word mean? And, you know, and also recognize we're all kind of rooting for the humans because, you know, that's our team. But that can give us a bias that leads us to wrong answers.
I think talking about bias, it strikes me that we've been sitting on all this data with patients going back many years for some patients. And yet, even though it's digital, I don't think we've ever systematically tried to sort of digest that. And now we're at this point where AI can do that for a patient, for all patients, for your institution. And it would seem to me necessary that we cross this threshold and quickly find out what we can learn. How do you see that?
I completely agree with that. And I also, you know, even if you're just saying, how do we support the physicians and other clinicians trying to do their work, the work has become impossible because of the amount of data that you're both collecting and you're kind of responsible for looking at and analyzing. And, you know, I've got 1,000 doctors that work in my department, and a lot of them are pretty grumpy. And part of the grumpiness is just the amount of sifting they have to do through records, the amount of time they have to spend doing documentation, the amount of time they have to spend answering email messages from electronic inbox messages from patients that could at least theoretically either be answered by or triaged by an intelligent automated system. And so, yeah, I think we have an obligation to figure out how to use these technologies in ways that help us do what we're here to do. I mean, we're here to make care better and safer and more equitable and more accessible and less expensive. And there's not that much doubt in my mind that the technologies will help us do that. What, you know, one of the things I have been struck with, and Eric and I have debated this over the years, I think if you look at the last 10 years of digital transformation in healthcare, you would say that the dominant theme is unanticipated consequences. The dominant theme is that it's harder than it looks, that even when the technologies look like they're going to just be massive problem solvers, the interface between the technologies and the systems and the politics and the money and the sociology and the culture is really tricky. And so I don't see any reason why this won't be even trickier, because in some ways it brings up more ethical questions than the electronic health record did. But I think we have an obligation to get it right. I'll make one more comment about this. Part of getting it right is if we looked at Stanford or we looked at UCSF or we looked at Scripps today, I'll just tell you in UCSF, we have 20 or 30 people that work for our health system whose job it is to take our data, analyze it using the best tools they can find, to deliver clinical and business intelligence to people like me trying to take care of patients like us. My older son, as you know, Abraham, works for an organization, and he does this. He analyzes their data. They also have 20 or 30 people that do that for a living. His organization is called the Atlanta Braves. And he has 20 or 30 people in his baseball analytics department, but the Atlanta Braves have a total of 400 employees. We have 20 or 30 people at UCSF, and we have 30,000 employees. So the resources that we have put into taking our data and taking these technologies and using it to get better at what we do are really it's an inadequate investment. Now that will become easier as the tools get better, but we're still going to have to kind of understand that it's going to take an institutional, investment to figure out how you leverage these tools to actually improve care.
Well, I think you're making an essential point, and it's also flanking that with the fact that the health sector has been the greatest expansion in jobs in the U.S. and most industrialized countries, and its growth is unchecked, and it's basically overridden retail, manufacturing. I mean, you name it, right? And so, if you're going to get the appropriate level of support for IT and AI integration, if that there's not room at this point with the growth of people, not just frontline, but all these people in the administrative management aspects. So, but that gets me to, there's many different proposed applications of large language models in AI in healthcare. The first, that one that you've touched on, is diminishing the documentation burden, the administrative aspects. And I don't know if UCSF is doing any pilots with some of the companies that are launching ambient voice conversation of clinic visits into notes and all the other things that come from notes. That one seems to be potentially near term, at least compared to some of the others that you aptly point out are challenging. What do you think about that prospect?
Yeah, I think I have a little pride of ownership when it comes to scribes, because the first article that brought scribes to national attention was written by my wife, who writes for the New York Times. And it happened because I came home and I said, honey, you know how every other organization, every other industry computerizes and immediately starts laying people off? Only in healthcare could we figure out a way of computerizing. And now we have to hire a person to come into the exam room to feed the computer. And she said, oh, that's a pretty good story. So what I said to people from the beginning is the need for scribes is tremendous, because you do not want your most expensive employee acting as a data entry clerk. But I wouldn't invest in a scribe company, because that's always seemed to me to be a tractable problem, that a human scribe pre-med student for $30 an hour, at some point, if you collected enough data, that should be something you can automate. And I think you're right. I think I've looked at a bunch of the programs, Nuance and Augmetics and others, and they clearly have mastered the basic visit. When I go to see my neurosurgeon in a week for kind of a stereotypical visit for a neck fracture, that could be done easily. A little tougher for an internal medicine visit where there are 8 different problems that are kind of woven together. But it does feel like if we haven't mastered it this year, it'll be in the next year or two. And I think that will be the dominant, this will become sort of a normal thing. You go in to see your doctor, have a conversation, there's some little Alexa-like device sitting on the table, and the note just appears. And I think it will be a great time saver, and will just be the start of the automation of the process, because it really isn't very much of a leap from it creating your note to then it suggesting differential diagnoses, and maybe even suggesting the right tests and all that sort of stuff, which, I guess I've been struck in clinical digital transformation by how extraordinarily little clinical decision support we get from our digital tools. And it's partly what pisses doctors off so much. We spend so much time feeding the computer and get so little useful intelligence out of it. But I think the digital scribes are sort of the lowest hanging fruit of what will ultimately be a huge amount of decision support for both clinicians and for patients and families.
Now, one of my, questions is what's going to happen to medical education? We're already seeing sort of a inversion of how we teach students from the way you and I learned, where, the student would go to the ER and interview the patient and gather the data and do their physical. And now they arrive in the ER and everything's already been done. So what exactly is going to be the role of the medical student with a new patient? And, I'm sort of trying to do a mind exercise on what this will look like with the third-year medical student, with the residents, when so much has already been done for them. The diagnosis is done more accurately by AI. The chart is populated. So, what do they do?
Well, I'd love to hear your thoughts on this, because I think, when I think about this issue, you're the person I would turn to. And I think, your article in the New England Journal about how the earlier stages of digitization were changing the dynamics of medical education was just masterful. I mean, I'd never forget the line where you wrote that the patient almost doesn't matter anymore. It's just the patient's there to keep their medical record alive and the electronic health record. It's just brilliant. So Yeah, I worry a lot about it. And I think, some of the studies on empathy are a little bit concerning because we all said, well, okay, the computer can make a diagnosis and computer can data gather, but you're going to have a human to do the empathy part. And the answer may be, maybe, and maybe the computer can do some of that too. I am a little skeptical of the usual party line answer, which is that computers and people are better together than either one alone. I think if you were the computer industry, that is what you would say to not piss off the doctors. But at the end of the day, you would love to replace the physicians. I think that's going to take a while. And I think that, at least for the foreseeable future, there will be clinicians who need to be well-trained using these electronic tools. They need to be able to vet the answers, which most of the time will be correct, but some of the time will be nonsense. But it is one of my biggest worries about computerization and training. When you look at other industries that are far more ahead of us when it comes to digital transformation, you see this inevitable problem of digital complacency. Basically, you see this problem where people begin turning their brains off because they become quite dependent on the computer doing their work for them. And that's not an irrational response. Humans like to preserve their neurons. And if the computer's doing this thing really well, why should you bother? And then the problem is when the computer doesn't do its thing correctly, will the humans be able to, do they have the skills anymore? Are they awake to, grab the metaphorical wheel? And, there have been some high profile accidents in aviation where when you looked at the root cause was a computer malfunction and the pilots no longer knew how to fly the plane when the computer wasn't helping them. And, and medicine's a lot more complicated than aviation. So we will have a very funky decade or so ahead of us where our trainees will get more and more dependent on the computer, will get a little sloppier and a little lazier in terms of sort of their rigor in data collection and in even thinking things through. And the computer will be wrong a fair amount of time. And I think that's challenge number one for medical educators like us. I was just asked to chair the Macy Foundation, which focuses on medical education, is going to focus on this. And we're going to be tackling this over the next year, sort of AI meets medical education. I think it's going to be fascinating. And I don't know, I know you're interviewing me, Abraham, but I'd love to hear your thoughts on where you think this is going.
Well, I'm not sure, but I continue to believe that we'll put a lot of premium on the phenotypic findings on the body until some AI robot can come and do the exam for us. My sense is that that's going to be pretty important, because if we rely entirely on what was said by somebody and what the labs show, and nobody has picked up, I don't know, the cafe au lait spot, the shingles rash, the xanthoplasma, then we're going to be missing something. So that's the piece that we can do, and that's the piece that I think we can train students to do better. But it won't happen unless we have a high-stakes sort of testing, because students study to the test. And if there is no testing at the bedside, then they're not going to bother with it.
Yeah. And a point you've always made is that the physical exam really is doing two things. It's not only an evidence-gathering activity, it's a bonding activity. It is there's something quasi-religious about the laying on of hands. And, if the computer can look in the back of your eyeball and detect whether you have hypertension or you're at risk for 73 different diseases, how much laying on of hands will there be? I mean, all of those skills are eroding very quickly even now. And that's when the digital tools are really pretty unimpressive. And I think as they get more impressive, I think it'll be very, very hard to hold on to them.
Well, that goes back to my aspiration that the gift of time could ultimately be restored, because part of the problem of not doing an adequate or any physical exam, the WNL, we never looked stuff,
right?
Instead of within normal limits, that, is partly because of this squeeze of time, the big business of medicine, and the clinicians are less time with patients than ever. But that gets me to the patient side of this, because we physicians tend to think more about our own community rather than the patients. And already, I don't know about you, both you and Bob and Abraham, I'm seeing patients come to me in clinic who are using GPT-4. They go to Microsoft Edge, they go to the Creative. They're not using Google search anymore. And they're getting a lot of different information they would have gotten from a routine Google search. And there's no FDA, rules about patients doing a Google search. And I just wonder your thoughts about the fact that patients are having access now to a synthesis of data that's surprisingly so up to date, particularly with GPT-4, that wasn't frozen back, in the middle of 2021. And it's really, I don't know what we call it, but that's not leveling the playing field of knowledge, but it's doing something we've not seen before. What are your thoughts about it?
I think it's net pretty exciting. I mean, I have always believed that democratizing care is a good thing, and you, Eric, have been a real leader in making that point and making the point that technology can facilitate that. Where democratizing care gets scary is when you've democratized it, but people don't have the tools to actually get accurate information. And so they are trying to be their own doctor, but they're dealing with BS and misinformation and all that. So if we could guarantee that the output they get in GPT-4 is going to be accurate and a reasonable synthesis of the literature, and make clear that this thing you can handle yourself, but this other thing you actually need to see a credentialed professional, I think that makes the world a better place. I think it improves access to care. I think it makes patients more informed. It is interesting, until you said that, I hadn't really thought about, the Google search, because it just gives you a bunch of links, doesn't really synthesize for you. And so you may hit 5 different links, and now, you're clicking on each of them, and this one's way too scientific for you as a patient, and this one is written in play language, but it's not up to date, all that kind of stuff. There's something interesting about flipping that switch to something that's basically a synthetic cliff notes of the state of the literature, which of course is, I think GPT-4 does it magically well by and large. And, the early hit on hallucinations was real and still is real, but less of a problem in the newer versions than the old ones. But the fact that it's synthesizing the literature is an act that we have to approach with a little bit of skepticism, because if any of the 3 of us were asked to synthesize the literature, I have a C3 fracture. When should I take my neck brace off? I know when I want to take it off, which is like now, because it's horrible. I've spoken to several different neurosurgeons. They all have different opinions. If I put into GPT-4, which I did, it has sort of an opinion about when I should take it off, which is a synthesis of a whole bunch of different things. But it turns out there's no right answer. The literature does not exactly lead you to the right answer. It gives the illusion that there is one answer. But, the same thing is true when you go see a doctor. The doctor's going to tell you what he or she thinks about a given situation. So it's an interesting flip in its conversational tone, and the fact that it's not sending you to the original links, which is both potentially useful but also potentially confusing for patients. And it's giving you an answer in plain English about your situation. I think it's really exciting. I think it's a net good. But like all things that we democratize, it leads to unanticipated consequences that we're going to have to deal with, and there are going to be more and more. There are going to be more and more businesses that pop up whose basic rationale is, the healthcare system's too expensive, and you can manage yourself, or we can help you manage yourself without all those expensive, RNs and MDs around, by using some combination of AI and GPT and some other hocus pocus. And, there'll be some people that get in trouble with that as well.
What about regulation? I'd like to ask both of you. How do you see regulatory bodies policing this access to data? Should the data be regulated in terms of this is quality data, don't go into that kind of literature? Should they be paying for the data that they access that belongs to us as a writer, for example? Do I really want ChatGPT to go through all my novels and synthesize something from there without paying me a fee?
Yeah, no, I mean, the number of really thorny problems that this is going to present at every level of our society is the sort of, the more you think about it, the more your head hurts about, like, how's that going to work? How's that going to work? I think in the healthcare world, yeah, I mean, and I think the issue of for authors or other creatives, you're right now, it can go and sift through your 5 or 6 books, and somebody could say to it, write me another book about a new topic in the style of Abraham Verghese, and probably do a half decent job. And probably have a royalty fee a little bit lower than yours. So it's going to be very, very tricky. In the healthcare world, I think the correct answer is I don't have any idea. I mean, I think the idea that all the algorithms are going to be somehow vetted and regulated, when in a big healthcare organization like the 3 of ours, there are going to be literally hundreds of algorithms, every day, helping to manage everything from, assessing fetal heart rate monitors in labor and delivery to predicting bad outcomes for patients in the OR. And those algorithms are going to be changing all the time based on the data that's being fed into them, which is going to be real time. And how you create a regulatory framework for that sort of prophylaxis against bad outcomes, bad data, I don't have any idea. I mean, I sort of can't imagine that it's at the level of each individual algorithm, the way we think about the approval of a drug by the FDA. I think it more has to be about the process and the way the system that's producing the algorithms has the good housekeeping seal of appropriate expertise and appropriate guardrails against biases and appropriate updating and all that kind of stuff. But I think it's, all these problems are absolutely daunting. It can't be that the right solution is to create such a straitjacket of regulatory control that any of our 3 organizations can't take the advantage of the data in our electronic health records and the data in the medical literature and try to come up with algorithms that allow us to provide better and safer and cheaper care. I mean, that can't be the answer. So, the answer's got to be not that. And the answer also can't be completely unfettered Wild West. And I think everything in between is fair game at this point. But you're going to need smarter people than me to try to figure this one out.
Yeah, it's interesting, Abraham, you brought that up because, we now have over 500 algorithms that are cleared or approved by FDA, AI medical algorithms, and almost none that are in daily practice. So the regulatory part wasn't so much the determinant, but rather implementation has not been widely adapted just because there's no publications for most of these. There's no data transparency. And so the willingness for health systems to fork out funds to buy these tools is limited, no less the medical community's willingness to buy into using them. So it's interesting. And we just published, Bertalan Mesko and I, a paper on large language models and regulatory in Nature Digital Medicine. And just as Bob aptly points out, I mean, there's a fine line. You have to catch the right medium balance between stifling the progress and not letting this go into jungleoid activity. So, but perhaps beyond regulatory, it's really the lack of transparency, which is a serious issue, which, these companies that are doing these algorithms are rarely publishing their data, and their algorithms are typically proprietary. They don't even want to let anyone know what's the secret sauce. So there's some issues that, as I think, Bob has reinforced over many years, the digital transformation has lots of bumps in the road here, and that's just another one of them. I think the other question about AI, Bob, that I would like to get your sense about, there's a future that's beyond where we are today, with not just patient questions, the front door, or not just fulfilling documentation stuff, but the more far-reaching aspects of hospital at home. That is, we have multimodal data on any given person, why have them in a hospital? I mean, that's your frontier, the hospitalist. But not talking about ICU, but the regular hospital rooms. Could you see randomized trials that are conducted with the appropriate sensors and all the other data fields, whereby patients will be safer, less expensively handled, managed, treated in their home bedroom rather than the regular hospital room? What do you think about that?
Easily. I mean, I actually don't think you need more randomized trials. For hospital at home, I have always contended that what you need is, if you walk into the ER at any of our 3 hospitals today, and there's a patient sitting there who let's say looks like me last week, and you feel like the patient could be cared for just as easily at home versus 10 floors up. And to get that patient home, you have to make one phone call, admit to hospital home, the same phone call that you make to say admit to 12 long. I think then it would take off. But today, you can't make that one phone call. It's going to be the nursing, the physical therapist, the home IV, the oxygen, the logistics. How are we getting an X-ray? How are we going to get a blood draw? And the only way that was going to happen was if companies emerged to basically do supply chain to support hospital to home, and no company's going to emerge because there's no business there. So you had this sort of circular problem that until the regulatory environment got more favorable, the payment environment got more favorable, and also enough hospitals closed so that the remaining hospitals are running 100% full and really have an incentive not to admit the patient. So the economics and the regulatory environment had to be such that then a venture capital invests in this, these companies emerge. It's sort of happening now. I have no doubt that, particularly with more advanced sensors and AI, that 10, 20, maybe as much as 30% of hospital patients could be cared for well, safely at home. I think the literature is very supportive of that. But it's a fragile ecosystem because even in the regulatory environment, there were some concessions toward it during COVID, and Medicare has just said, all right, we're not going to re-erect the barriers, but we'll only give 2 more years and we'll take another look. So that it's a little bit too uncertain for the entire ecosystem to come around and develop the infrastructure that I think is necessary for it. Once that's developed, I just have no doubt that it's better. I mean, we'll need fewer hospitals. The hospitals that we have will be mostly ICUs, will be really, really, really sick people. And I think for most people, they prefer to stay at home if you can figure out how to do it safely and cleanly. But cleanly really is that you make one phone call and all of the logistics are taken care of. And that's non-trivial.
But just to wrap things up, it's pretty clear that the recent head trauma and COVID you sustained has not interfered with your brilliance and wisdom. You passed the cognitive test.
Oh, thank you.
This is a super Turing test that you transcended beyond. Really enjoyed this discussion with you, Bob. We touched on so many things. Two of our favorite topics, of course, in the wake of the COVID. That's kind of, as you said, it's going to be with us for many, many years ahead. And then the AI future, which has its challenges, but hopefully the net will be one that will improve medicine and improve outcomes for patients. So thanks so much for being with us.
Well, it's a joy. You're 2 of my favorite people and role models. And I'd say, even if we were just doing this over beers somewhere, that would be great. I'd love to do that as well.
Let's do that too.
That sounds great.
Thanks for being here, Bob.
My pleasure. Great to see both of you.